I had a presidential lecture on September 28, 2024, KINGCA Symposium. The topic was endoscopy and gastric cancer. In 1993, Korea Gastric Cancer Research Group was established. All surgeons at that time. 10 years ago, the KINGCA Symposium was held in Daejeon. I attended the first KINGCA Symposium with some of my senior physicians. 2 years of work at KINGCA leadership has been a very glorious period for me, and I want to appreciate all the KINGCA KGCA members for giving me a chance to work as a president, which I really enjoyed and learned a lot. Especially, I want to say thank you to KGCA Chairman Professor Keun-won Ryu for his continuous support. KGCA is a multidisciplinary society. In a 2017 workshop, I had a presentation why we need to be a multidisciplinary society. The answer is simple. It's because the treatment of gastric cancer is based on a multidisciplinary approach. However, when we look at the proportion of our members, the majority, 73%, is surgeon. Physicians, including endoscopists and oncologists, are only 16%. Pathologists and radiologists is only a few. So we need to recruit more non-surgeon members. I believe my next president also knows it very well. Anyway, as an endoscopist, I'd like to talk some of the issues of gastric ESD. The incidence of gastric cancer in Korea is slowly decreasing. During the last 20 years, the age-adjusted incidence has decreased about 32%. The reason why is unclear but should be multifactorial, such as Helicobacter eradication, better hygiene, nationwide screening program, and active treatment of gastric dysplasia. However, Korea is still number 3 in the incidence of gastric cancer both in males and females. However, the treatment outcome is excellent. Globally, the mortality incidence ratio is quite similar both in developed and developing countries. The only 2 exceptions are Korea and Japan, where the screening program is well established. This is the overall performance of National Cancer Screening Program for gastric cancer in Korea. In 2022, the participation rate was 63%. Among them, 93% was done with endoscopy. One special aspect of Korean cancer screening is the opportunistic screening. The proportion of opportunistic screening for gastric cancer is not clear, but seems to be about 20%. Therefore, the overall gastric cancer screening rate in Korea now is about 80%. The proportion of localized cases of gastric cancer increased from 53% in 2009 to 66% in 2021. Detection of gastric cancer in early stages lead to the increased number of endoscopic treatment and less invasive surgeries. The Korean government regularly monitor the quality of gastric cancer treatment. This is the 2019 audit for gastric cancer surgery and endoscopic resection. In this program, more than 22,000 cases with gastric cancers from 2008 institutions were enrolled. Surgical resection was done in 60% and endoscopic resection was done in 40%. Among cases with endoscopic resection, additional surgery was done in 8.7%. So the volume of endoscopic resection is really large. From now on, I'd like to briefly tell you about my personal history as a therapeutic endoscopist. This is the first small clinical report on endoscopic treatment of early gastric cancer in Korea in 1996. Professor Hyun-chae Jung performed all the procedures, and I was the first author of that report. At that time, I was a senior resident at Seoul National University Department of Internal Medicine. Thank you, Professor Jung. I started endoscopic treatment of gastric cancer in 2003. This is another early ESD procedure. At that time, I used the flex knife. I also learned a lot from seminars and symposiums. This was the first ESD symposium in Tokyo in 2004. 제1회 내시경 점막 절제술 연구회. Maybe it was at Shinagawa. Major topics were development of strip biopsy, indications of colonic EMR, early years of endoscopic treatment, and meeting point between physicians and surgeons. Two years later, the first Korean EMR symposium and live demonstration was held in 2006 at Severance Hospital, Seoul. Famous professors from Korea and Japan had lectures and live demonstration procedures. Pathology evaluation of the ESD specimen is of paramount importance. At that time, we had regular symposiums with pathologists. We had a great debate on the adequate price cost of the ESD procedure. In 2011, after a few meetings between government officials and hospital leaders, insurance coverage was determined. The yellow circle was me. I attended the meeting with my boss. I also had a great interest in ESD education for the beginners. Left-hand side is KDDW and right-hand side is JDDW. At my institution at Samsung Medical Center, gastric ESD is done about 1,000 cases a year. In the recent 5 years, the rate of gastric cancer among ESD was 73%. The rate of additional surgery after ESD for gastric cancer was 15%. I am very happy and proud of being a member of this excellent team. Thank you so much. From now on, I'd like to talk about ESD indications based on the recent KGCA guidelines. Statement number 4 is about absolute indications. It says, endoscopy resection is recommended for well or moderately differentiated tubular or papillary EGCs with tumor size less than 2 cm, mucosal cancer, and no ulcer. The red box shows absolute indications. Statement number 5 is about expanded indications. Both ESD as well as surgery can be indicated for expanded indication regions. This is expanded indications. Both surgery and ESD can be done. This is a recent Korean multi-center retrospective study about ESD for undifferentiated type early gastric cancers. 728 curatively resected ESD cases and 383 surgery cases were enrolled, and propensity-matched outcomes were analyzed. In all cases, the overall survival was higher in surgery group. However, after propensity score matching, there was no significant difference in the overall survival between the ESD group and the surgery group. There was 2 cases of distant metastasis among 328 ESD cases. There was 6 lymph node metastasis among surgery patients within expanded indications. The authors concluded that although ESD showed comparable outcomes to surgery for the undifferentiated type EGCs within expanded indications, appropriate patient selection is needed for the ESD due to the possibility of lymph node metastasis. Currently, a prospective clinical trial about ESD for undifferentiated type early gastric cancer, ERASE-GC trial, is ongoing in Korea. This is the current status of patient enrollment of the ERASE-GC trial. The target is 708 patients and more than 650 were enrolled right now. In the recent guideline, Statement 6 is about undifferentiated type early gastric cancers. It says ESD should be done, but cautiously and after sufficient discussion. The evidence level was low, and the recommendation was conditional 4. Surgery is usually done, but ESD is currently performed in many institutions more often than before. The dotted line means conditional 4. Next topic is management after ESD. Regarding additional surgery after ESD, I'd like to briefly touch 2 aspects. In order to predict the risk of non-curative ESD, we developed a risk scoring system. We found 6 independent variables such as pathology and size and others. Based on the relative risk, we made a score for each variable. This is the correlation between the total risk score and the predicted risk of non-curative ESD requiring gastrectomy. As you can see in the previous case, survival benefit of additional surgery after incomplete ESD is well established by many reports, including our experience at Samsung Medical Center. In terms of the overall survival, additional surgery was related with better outcome. Survival benefit was shown in a propensity matched study by Dr. at Korea National Cancer Center. As you can see at the right-hand side picture, the overall mortality of observation group was higher than that of the matched initial standard surgery patient. In the surgically resected specimen, residual tumors is found in about 10 to 20%. In our experience, the rate of lymph node metastasis was only 5.7%. However, do you think surgery is always necessary for mucosal cancer with lymphovascular invasion? Red box is the traditional absolute indication group. In the SMC cohort, there was no lymph node metastasis after surgery in this group. Careful observation without additional surgery can be an option for this group of patients. Next will be short comments on issues for future research. In the real world, almost half of the patients with non-curative endoscopic resection choose observation without surgery. Although 5-year overall survival is much better in the surgery group, but the 5-year disease-specific survival in the observation group is more than 95%. This is a Japanese chart for risk factors of lymph node metastasis after non-curative endoscopic resection of early gastric cancer. Yes, it is useful, especially for younger patients to make the informed decision. But I feel we need to consider factors other than lymph node metastasis to guide very elderly patients. It is uncertain when to stop yearly endoscopy follow-up after ESD. It's because metachronous cancers can develop even after 5 to 10 years of ESD. In this representative case, the patient skipped yearly endoscopy for 2 years and an advanced gastric cancer was found. Surgery was done. We need more data on this. Standard treatment for Helicobacter positive multiple lymphoma is the eradication treatment. However, approach to the Helicobacter negative multiple lymphoma is still challenging. In some institutions, ESD is tried for Helicobacter negative multiple lymphoma. Finally, I'd like to briefly show you how I teach young endoscopists with an internet site and hands-on trainings. I started my personal internet endoscopy education site named serioso.pe.kr in 1999 when I was a military physician. It's already 25 years ago. After changing the name into EndoTODAY.com, I made it a mobile-friendly, YouTube-linked, interactive educational platform, and I'm proud that so many young endoscopists, not only physicians, but also surgeons and family medicine doctors, regularly visit my educational resources. With a great help from colleagues at Samsung Medical Center, I can establish a lot of educational hands-on training courses like gastroscopy box sim, colonoscopy box sim, stent EUS sonography. Among them, I'd like to show you some of the EndoGel ESD hands-on training courses. ESD training should be stepwise. It starts with basic training with an ESD training bed. Next step is EndoGel ESD, ex vivo pig stomach ESD, live pig ESD, and finally the real clinical case ESD. This is the EndoGel ESD training setup. We teach two procedures. The procedure number 1 is a pin knife method using dual knife, flush knife, or M knife. The second procedure is an IT2 based method. This is a procedure number 2 with IT2 knife. In this high-speed video clip, you can see that endogel ESD is quite similar to the real case procedures. I recommend to exercise the endogel ESD 5 to 10 times, and then ex vivo pig stomach ESD, and then live pig ESD, and then finally you can do real case ESD with your teacher. In the real patient ESD, there are trainer steps and trainee steps. Before starting ESD for the first time, beginners should have some experience as the first assistant. With some cases, the main operator usually gives the beginners to do part of the ESD steps. Young endoscopists with a lot of hands-on training can resect this kind of small lesion in the easy location, posterior wall of antrum, without difficulty. Okay, this is the pathology. 6 mm muscularis mucosa cancer without risk factors of recurrence. Digital pathology really helps us to understand the final result. Well-differentiated adenocarcinoma limited in the mucosal layer. This is how I explain the final result to the patient. Sometimes I receive a letter with this kind of image. One of my young fellows got a new position at a small local hospital, and this is his first and 100% independent ESD. He must be proud of himself. This is his long history of setting up an ESD procedure at his new hospital. Previously, we had a big congratulation party after the first successful ESD by a young endoscopist. In the recent Korean medical situation, however, a big party is difficult due to so many night duties. Instead, I prepared a card with a gift, a French Pinot, my favorite wine for my junior doctor. Congratulations. For the foreign doctors, 1-week ESD training course is also available at my institution. It consists of introductory lectures, ESD observation, ESD conference, and ESD planning session, pathology conference, hands-on training using endogel ESD or live pig ESD. Recently, Dr. Fies and Dr. Febs visited my training center for 1-week ESD training. As a future direction, I'd like to comment on 2 issues. Recently, more and more people got Helicobacter eradication treatment. As clearly explained in the recent review by Professor Sun-Young Kim, the cancer location and cancer histology is different among Helicobacter negative, Helicobacter positive, Helicobacter treated population. So, screening policy and endoscopy strategy can be or should be individualized based on the Helicobacter status. We need more data on this topic. We need to develop more endoscopists for the screening and symptom evaluation. As the National Cancer Screening Program data shows, the number of endoscopy is huge. About 8 million gastroscopies were done in the government program in 2022. This number does not include private and opportunistic screening. Not only endoscopists, special gastroenterologists, but also general physicians, surgeons, family medicine doctors are involved in the National Gastric Cancer Endoscopy Screening Program. There is a debate on who will teach whom at what platform. I am Professor A at this 청년의사 article. In my opinion, open education is the answer. The answer should be the open education. Everyone who wants to learn endoscopy should have enough chance of learning. My endoscopy education is open to every doctor. International cooperation in endoscopy education is also very important. This is a picture at previous KINGCA masterclass at my institution. I think they really enjoyed the boxing training. Ladies and gentlemen, I'd like to conclude my presidential lecture by saying that KGCA has become a multidisciplinary society. Still, we need to recruit more endoscopists, more oncologists, more pathologists, and more other specialties. Indications of ESD have been rapidly expanded, so we need to collect more data from clinical trials and real-world cases. I believe the medical education should be open. Thank you very much.